Thank you for joining us today for our fourth webinar that the FNSD SIG has hosted. We are very excited to have Julie Gardner and Tanya Ragan here today to talk about navigating FNSD in the school setting. So a couple of things to note. We are going to be recording the webinar today. It usually takes us a couple of days to get everything from the cloud and sent out. So if you registered, you should be receiving a copy of the recording by the end of the week. We will also post the recording to our FNSD SIG website. The website, for those of you who aren't familiar with it, is listed on this slide. Please check it out. There are a lot of great resources on the website, including our past webinar recordings. Just a note about questions. Please use the Q&A function to ask questions. We are going to have time at the end for Tanya and Julie to answer questions. So if you have questions throughout, feel free to put them in the Q&A. We'll be monitoring those, and then we'll save some time at the end to hopefully answer them. Okay, so is everyone, I think all of our panelists are set to go, so we're going to go ahead and get started. So we are going to have both Julie and Tanya share their experiences today on navigating FNSD within the school setting. So first we're going to have Julie Gardner, who's an educational specialist at Kennedy Krieger Institute, presenting. And to give a little background about Julie, she received her BA in special education and elementary education from Flagler College and her MA in varying exceptionalities from the University of South Florida. Currently, she is a doctoral candidate in special education at Slippery Rock University. Julie has a special interest in FNSD and chronic health impairments and their impact on education, which is actually the focus of her research at Slippery Rock. She has been with Kennedy Krieger for 20 years and previously was an administrator in public, non-public, and private sectors. So Julie, go ahead and take it away.
Thank you, Caitlin. Like Caitlin said, this is a special area of interest of mine, so thank you guys for having me, and I'm looking forward to the chat today and hopefully sharing some insights from some of the work that I've done with these patients in the public school. Next slide, please. So I kind of wanted to start it off with defining the difference between a couple of different programs in schools that help students with special education and related needs. I think these are two terms that sometimes can get confabulated a little bit, and so I wanted to make sure that we're talking about the same things as we go through this presentation. So as many of you know, an IEP is the individual education plan, which is the program for students that require special education in the public school system. It is regulated by the IDEA, which is the Individuals with Disabilities Education Act. And it is kind of the difference between the two is that the one that sets it apart is that this is for students that require specialized instruction. And we'll talk a little bit more about that in a little bit. In order to qualify for an IEP, you have to meet the eligibility requirements under one of the 14 federal handicapping codes, which are now known as primary disabilities, and those are defined by the law. So we can talk about those specifically if people have questions about that. The big difference between the two is, like I said, the specialized instruction. When we talk about students who are in general education, which many students with FNSD are, those are the students that will go through what we call the 504 plan process. It is a different law altogether. Oftentimes the 504 was known as sort of the booby prize. If you didn't qualify for special education, you kind of got shunted over to the 504 team, but they are two very different laws and two very different sets of services. The American with Disabilities Act is the law that regulates this one, and this is a series of accommodations for students with medical or psychological disabilities in the school setting. The These 504 plans are reviewed once a year, but can be reviewed as often as possible. And that's important for kids with FNSD as they change over time. So they don't require additional district funding. They're often a lot quicker to receive services through. So as we go through today, I think we're going to be sort of talking more about 504 accommodations than we are the special education. Next slide, please. So some other terms that often get misinterpreted are supports, accommodations, and modifications. So in thinking about the services that kids with FNSD require, I often kind of highlight these three areas for our providers. When we talk about supports in the public school system, that is typically for all students. So it's things like allowing kids to leave the room to get a drink of water, allowing kids to go to the guidance office if they need it, extra reminders, things like that. So it's sort of those typical good teaching strategies that we use. When we talk about accommodations, though, those are reserved for students that either have a 504 or an IEP. In order to qualify for accommodations in school, you're required to have a diagnosis, so an identified educational disability or a medical diagnosis that's been documented. So when we think about accommodations, oftentimes we think about things like the SATs. Does a student require extra time? Do they require breaks in class that are beyond what typical kids would be getting? Things like technology, so speech to text or text to speech, those are kinds of things that are considered accommodations in the public school system. And these are supports that allow kids to access the general ed curriculum. And what that means is that students who have accommodations through a 504 typically are still receiving the same education that everybody else is. They just need these additional supports. When we talk about the word modifications, which is something that I see a lot of times in provider recommendations, modifications are things that change the curriculum altogether. So we're talking about things like alternative assignments, alternative criteria for mastery. We're talking about true special education that is very different than the typical students. And I want to be clear about these three because a lot of times, like I said, they often get interchanged in reports. And so we want to be really careful when we're talking about what we're asking for public school teachers to do. Next slide, please. So when I think there's another part to this. Yeah. When I have worked with students all over the country, returning kids to school after they've been either inpatient or in our outpatient program. And oftentimes when I see challenges with them returning to school, the problems fall in one of these 5 buckets. So I wanted to sort of highlight the 5 of them, and then we'll go through each one individually. We can go ahead and go to the next slide, Caitlin. I think the biggest one that is an issue for kids with FNSD is the stigma and misunderstanding of the diagnosis in general, right? As we all know, and I'm not telling you anything you don't know, mental health disorders in this country carry a huge stigma. I think it's getting a little bit better, but it's still difficult for schools to understand, difficult for teachers to understand, and for students with FNSD in particular, because of the inconsistency of the symptom presentation. A lot of times teachers will say that they believe that the students are feigning or faking symptoms. They don't believe there's a real diagnosis. They say it's a typical teenager behavior, things like that. So overcoming that stigma is a huge part of what I do when I go out to schools to help with reintegration. Unfortunately, school violence has brought mental health issues to the forefront. We talk a lot more about it these days than I did 20 years ago when I started at Kennedy, but it's still not as accepted as if there was a physical disability. The talk about mental health issues in the school, I think there's pros and cons to that, right? Because a lot of people attach that to school violence. Mental health and school violence sort of go hand in hand. But for kids with FNSD, talking about mental health in a very different way is very helpful for staff. Next slide, please. The other piece of this is when we talk about in the clinical setting, I know a lot of us sort of talking about FNSD, talking about mental health disorders, talking about physical health disorders, chronic health impairments, that is all second nature to us. But for those folks that are working in the public school system, they don't have any of this training that we do, right? So general ed teachers, they have tons and tons of training. They have tons of professional development. They may have 1 or 2 professional developments across the year, if that, about chronic health impairments or mental health impairments. But that's it. They don't have the background that we do. Special ed teachers often understand special ed disabilities, which are those things that help identify for special education. But for those kids that sort of fall in the middle of both of those, there's very little training out there in the schools. Rarely do they have training on any medical diagnoses, let alone FNSD. But again, the mental health disorder world is starting to come into the schools a little bit more, which is helpful. But I don't think we're near where we need to be specifically for kids with FNSD. Next slide. So as we all know, leading to a diagnosis of FNSD often takes a long time. And so what happens to a lot of kids is that they're getting treatment from different providers across their trajectory of symptoms. And so each time they go to a different provider, they get more recommendations, and they take those into the school. And so lots of times schools are on the receiving end of lots of different recommendations from different providers, and they're not always cohesive. In my experience, pediatricians are often the ones that the first stop for a family that's having difficulty, for a child that's having difficulty, and the pediatricians often will say, well, go to special ed and see what they can do to help you. And that's not always the best place to go. Special education requires a lot of formal assessments through the school, which can often take between 90 and 120 days in some places. And all that time, the students aren't getting the supports they need. And so that lack of understanding on the medical providers side of what is the difference between the two can sometimes really pose some challenges for the kids in school. And then when teachers do receive those reports, they don't always understand them, right? They're written sometimes in medical jargon, sometimes in psychological jargon, and the school teachers just really don't understand them. And often it's the nurse that gets tasked with interpreting those reports for the school. And again, as we know, nurses don't always have the training they need either, and specifically in FNSD or chronic health impairment. So what I've been doing is asking for the school psychologist to be a part of those teams. And when we first have a student who's getting ready to reintegrate, I always ask for the school psychologist to be on the team to help interpret those reports and to help explain FNSD. If anybody on the team is going to have that background, it's usually the school psychologist or maybe the guidance counselor. So those are the folks that you really want to integrate as early as possible on your team. Next slide, please. And the interesting thing, and I find this happening most often in the high school and maybe sometimes the middle school level, is that the classroom teachers are not even at the meetings where these diagnoses are discussed. Often the law says that the general ed teacher has to be at the table, but it doesn't always have to be that child's general ed teacher, which can be a challenge. Sometimes it's the PE teacher that sees the student once a week or is going to have the student next semester. It's not the person who's actually working with the student. And so that information is often translated through 2 or 3 different people before it actually gets to the folks that are working with your students. So that's something to think about too, in terms of who to make sure is at the meetings when you're reintegrating students back into the public school. Again, the students are often seen by multiple doctors. One thing that I often spend a lot of time with our families sometimes are concerned about the stigma of the diagnosis. So I spend a lot of time talking with families about the diagnosis, about how to share it, about what to disclose, about why it's important to disclose the diagnosis to a school. If the families don't want to share the diagnosis, it really sort of ties the hands of the school staff. So the communication between the medical provider and the family, and then the family and the school, are vital in order to get the student the services they need. Sometimes families are really reluctant to share an FND diagnosis in the school. And I think a lot of times it's partly because the family hasn't fully accepted the diagnosis, or they don't fully understand the diagnosis and the impact. But that piece is vital for the school to really be able to provide the services that we're asking for. And then finally, just having conflicting recommendations for accommodations can be difficult for school personnel to work through. Schools are, by law, they have to acknowledge and respond to all recommendations that are brought to them. So if one provider recommends one thing and another provider recommends a conflicting accommodation, then the schools have to sort of make peace with that on their own, which can be difficult for folks that don't have the background. So the more streamlined and the more cohesive we can make recommendations, the better it is. Go ahead, Caitlin. And finally, just by nature, schools are sort of the slowest moving machine we have in this country. And a lot of the policies and procedures that have been put in place for years don't reflect our newer understandings of chronic health impairments and FND in the schools. So a lot of schools will have seizure emergency plans that require them to call EMS or to contact outside providers if a student has a seizure in the school or what looks like a seizure to them. So for students with FND who have functional seizures, if the school doesn't understand the diagnoses to begin with, then they're going to have a hard time looking at that policy and making any changes to it. So, you know, like in the same sense of the seizures, schools often have policies about students who appear to have a change in consciousness or a change in gait, which might trigger them to then call outside providers. So that's why it's really vital to include the school nurse in the education about FND. We here at Kennedy Krieger have a group of nurses and educators who go out and really work with the school nursing departments and around our state to help them understand that. And I know there's some other folks that are doing that in other states, but it's not widespread. So that's a huge part of what needs to get done, I think, for FNSD, so that we can help start changing some of those policies and procedures. Go ahead, Caitlin. So how can you guys help, right? So this is the important part about what can we do to help students get what they need. I think the biggest thing that, one of the biggest things that we always ask psychologists to do is to be clear whether you're really asking for modifications or accommodations, because if you inadvertently ask for modifications to the curriculum, you're going to sort of trigger that whole special ed process, which may not be necessary. If you're asking for accommodations, we can get a 504 team together much quicker. Supplementary aids and supports are things that can happen in the classroom with or without a 504, right? So a lot of school systems will put those things in place without a whole lot of red tape, for lack of a better word. I always ask providers to think about whether or not that school staff needs staff training. Without a provider recommendation for that, schools don't need to necessarily implement staff training for kids with FNSD, especially in underserved and rural areas. I think staff training is vital. I think that's true of a lot of diagnoses. So if you put that in your recommendations specifically, that the staff is trained by somebody who understands FNSD, then the school needs to respond to that and can reach out and get that training. Establishing a communication channel is really important. So I always find that one or two people in the school who really get it and use those guys to help get to the bigger staff, especially in, you know, large schools, high schools. Sometimes you're really relying on one or two people in the school to really communicate to the rest of the staff. As much as possible, providing written guidelines, any kind of resources, any kind of documentation of the diagnosis, that helps the school be able to go back and review it. So a lot of times when a student first is reintegrated into school and everybody feels like, yes, I understand this, I know what to expect, but then the student starts to have an increase in symptoms, or maybe the symptoms change or something looks different. If they can go back to your resources that you've provided, it's a whole lot better than them Googling it, because a lot of times that's what teachers will do and they don't always get the best information that way. as providers monitor and evaluate progress over time, it's best to provide those written updates to the school so that they can meet as a team and review your updated recommendations. Oftentimes these change over the course of a year, and it's important for the school to get that in a timely manner. Encouraging flexibility. I work with a lot of schools that are pretty rural, and so they'll get a recommendation from one of our providers, and they're not able to meet it exactly the way we intended for them to do that. So what I do is I talk to them a lot about, well, what can you do? What can you do in your area with your district resources, with your personnel resources? What are the things that you can do, and sort of be flexible a little bit with that so that they feel that they're making the changes and making the supports that we're asking them to without overburdening them either. And sometimes we do targeted support to staff. We provide specific training for specific staff members, and sometimes it requires even individualized consultation with individual staff members that are really struggling. I always say there's good people in every school. I think there are great staff all over this country, but I also think that there are times where we run across staff members that really struggle to believe the diagnosis, to understand it, and to support the students in a way that is very functional. So we will meet with them one-on-one and talk about their class in particular and what their challenges are in understanding and implementing recommendations so that the student can be successful. Next slide, please. And finally, the biggest thing that we can do is that first meeting when you're reintegrating a student back into the school. I always say, start with the administrator, start with the guidance counselor, and start with nursing at one meeting. A lot of times what happens is parents go to a clinic appointment, they get that summary at the end of their clinic appointment, and they bring it back to the classroom teacher. And the classroom teacher may or may not follow through with it. She may implement it in her class and not think to share it with others. She may not think bigger than the classroom or the team that the student is working with. But if you start with these three folks in the school, they're not only going to be able to see what the school can provide from a whole school level, but they're also going to know about the district level supports that can be offered. They're also going to know about training opportunities for staff. They're also going to be able to have access to professional development for staff. So I always start with those three folks at the school level, and then include the teachers. Once we've had that discussion with them and they're really understanding the diagnosis and the requirements of the recommendations, then I say, okay, now let's meet with the teachers individually with the support of these three people. And I think that's the most efficient and effective way to get students the accommodations and supports they need. As far as reports, I think the three big things that we can include are the diagnosis and a definition of it. A lot of times, just because we have the diagnosis doesn't mean folks understand exactly what that means. How the diagnosis impacts the child's access to education, because let's be honest, that's all schools care about. How does it affect them from 8 to 3? That's what they want to know. Because if we say that it generally affects fatigue and all those kinds of things, and they don't sleep at night, so then how does that affect them in the morning? We have to really talk about what is happening during that school day for them to be able to provide supports. And then the last thing, and this is a big thing, is the recommendations need to be specific to that student. So the reason for that is I see in reports from providers a lot that FND affects students this way, or this diagnosis may impact the student this way, but it needs to be specific to that child in order for them to understand that those are recommendations specific to the student and not just general recommendations that we make for all students connected to that diagnosis. And I think that's kind of a nuanced thing for providers, because just because it's true for most people with FND doesn't mean it's true for this particular student. And that's sort of the perspective that schools have a lot. So it's important to connect the diagnosis to this particular student, if that makes sense. And I think that's kind of it in a nutshell. I guess we'll be taking questions there towards the end. Okay.
So Julie, thank you so much. That was super insightful and helpful. And I think a lot of practical tips that we can make sure we're doing as providers to be more clear in our recommendations, and probably also directly communicate with schools better, which I know is challenging to do sometimes.
Yeah.
Um, we had two questions come in. I'm going to ask you one now, just because I think it's a little bit more pertinent to what you were saying. So I want to keep it fresh, and then I think I'll save the second one for both hearing your and Tanya's thoughts. But there was one question that came in saying that you had mentioned schools have to respond to recommended accommodations and modifications from medical personnel. Could you speak more to that? Like, what does that mean? What are they required to follow, or how are they required to respond?
Yeah, so in the law, what it says is that they have to, they're required to review any documentation that comes in. So if a provider provides like an after visit summary, for example, or they provide a report to the school, then the school has to meet to at least review those recommendations, and then to talk about whether or not that they can implement them. If a school says, no, we're not going to implement these recommendations, we just don't feel like it, they have to document why they don't want to do it. So either they're going to say, well, we don't believe that the student needs it, right? Which is one situation where we have to, that's why I'm saying we have to address how the diagnosis impacts them during the school day. So if they get a report and it just says, kids with FND, benefit from breaks, and it doesn't say Sally benefits from breaks because of these symptoms that she has with FNSD. The difference between those two is the school could just say, well, just because all kids, just because kids with FNSD, need breaks doesn't mean that Sally needs breaks. But now if you say Sally needs breaks, then the school has to say, well, we're not going to give Sally breaks because. And once they have to say the because, it has to make sense, right? So if she has a 504 and the school's refusing to give her breaks, they have to have some data on the other end to say, well, she sits through 5 50-minute classes a day and has never asked for a break, and her grades are all in the good, she has A's in every class. She never asked for a break. She doesn't appear fatigued. So they have to have some data on the other side to refuse that accommodation. I think that answered the question.
You did. Thank
Okay.
you so much. And yeah, if for any reason it wasn't answered completely, feel free to put that into the Q&A, or even in just the chat for everybody to see. So thank you so much for that. I really appreciate it. And I want to give some time for both you and Tanya at the end, just to answer people's questions and just chat as a group, because I know you guys are full of a lot of knowledge. So I'm going to pass it on to Tanya, who is really wonderful, and we're so lucky to have her today. She is coming to us kind of directly from the school system itself, which I think is a really unique perspective. So let me give a little bit more background on Tanya Ragan. She resides in Alabama currently with her husband, Michael, and her 20-year-old son, Landon. She has an associate license in counseling, as well as several degrees in the field of counseling. Tanya has an educational specialist degree in school counseling as well, and a Master of Science degree in community agency counseling from Jacksonville State University. She has a Bachelor of Arts degree in psychology and human development from the University of Alabama. She's a certified facilitator in several programs, including Mental Health First Aid, Trauma-Informed Classrooms, Parent Project, Peer Helper Plus, Managing Crisis Safely, and Extended Family for Kids. Tanya has been in the field of counseling since 1999, so she's been doing this for a while. She served during a 10-year span as the historian, president-elect, and president of Chapter 5's division of the Alabama Counseling Association. And at this time, she's an active member on the board of directors for Extended Family for Kids, as well as a member of the Jacksonville State University's Counselor Education Advisory Council. This year, congrats to you, Tanya. You're beginning your 20th year in the education profession. So you're really, really fantastic. She's been a school counselor for 15 years, and speaks to us, I think, today directly regarding some of that role that she had as a school counselor with managing FNSD in the school setting. Currently, she's actually the mental health services coordinator for the Etowah County School District, and she's been doing that for the past 5 years. So we're really, really thrilled to have you, Tanya, and I'm going to take it away, or let you take it away.
Okay, thank you. I'm going to just highlight what Julie has already spoken about today. That was a great job, Julie. First of all, I would like to say, coming from an educational institute and on behalf of educators, probably this diagnosis is one of the hardest to navigate in a school system. Just because the symptoms are so intense and there's so much, the educators feel like responsibility, especially in our nurses in the schools. What I've seen is they feel like everything about this diagnosis looks like it should be treated medically. And so that's why I think it is so important, like Julie was saying, for awareness. Knowledge is power for us all. So especially for educators as well, is to let them know what this is, and let them know that the symptoms could look like tremors, difficulty walking, actual grand mal seizures. That was my experience that I'll talk about in just a minute about it. But also it can also loss of consciousness. There's several different ways that symptoms will manifest with this diagnosis. And so just making sure that they understand that this is not medical, that this is something that we as we are in that child's life, no matter how old that child is, and we have a role and a responsibility, but we could harm the child if we by calling in medical professionals, by calling 911. And so that's something that Dr. Fobian had shared with me that was it helped me when I was actually firsthand in a situation with a child with this diagnosis. But now in my role, I'm able to help the educators understand that, every time you call 911, we're bringing more attention, we're delaying their treatment process of getting well, and the treatment plan that the medical professionals has written for the kids, it's so important that we follow. But also another thing I see being in a school is because of the intensity of the symptoms, a lot of times the schools want to do homebound, and because they don't feel like they're equipped to be able to manage in a school setting, and just giving them through the power of knowledge of yes, we can do this, because that's not helpful for the child as well. In a lot of cases, sending them home like we've got to work through this and we can do this as a team. It can be a journey that we're all on together to really, with the relying on one another to be able to navigate through all of this, to help that child with what we all want. And the goal is for them to be able to be successful and have a good quality of life. And so, and just, letting them know on the awareness part that the symptoms present as a response to the present situation. So we're not damaging them by not calling in medical professionals, like we're working through this with them. And I'll speak more on that in just a few minutes of how we did that. But also letting them know that, this is hard for educators, is that it's so unpredictable when we would see these symptoms, and that one day they may be fine, and that, that's perfectly normal, but then the next day they may not be. And that's confusing, because there's not really, in an educator's eyes, they don't see like any kind of trigger to this. And so, but letting them know that, the symptoms are real, and the students, they're not faking them. That's very important, to take that stigma, like Julie had talked about, away. And that the stress, trauma, or past experiences can sometimes trigger these symptoms. So just the first piece of it, I think, is knowledge, equipping educators with knowledge. If I can have the next slide. So how my journey with this disorder, I had been in the field since, like she said, 99, and I have never heard of this disorder until almost a decade ago. And that's where I met Dr. Erin Fobian. She's on the panel as well. She was working with one of my students. It was a 17-year-old female, and at the time she was diagnosed with conversion disorder, which now we know is FND, and generalized anxiety disorder. What her symptoms presented as is non-epileptic seizures, stuttering, and memory lapses. This child came from a nuclear family with a mom, dad. She had a 9-year-old sister at the time, and her sister was actually a childhood cancer survivor. So we know with that history that there were some challenging times in that family. But But the adolescent that I worked with, she was a junior in high school. She was an AB student. She was our school mascot, where I was the cheer coach during that time, and she was a volleyball player. So if you would do the next slide, please. When she first was diagnosed, Dr. Fabian reached out. Her parents, who I did not really, I didn't have a relationship with other than just knowing them as a community family, a family in our community, they had reached out first and said that Dr. Fabian would be calling me, and that their daughter had been diagnosed with this diagnosis, and that, you know, that they would need some support from the school. And so when Dr. Fabian, she reached out and she was explaining like the symptoms that that would present within if she had these episodes, what, like, she would give me like guidelines of how to navigate that through space. And I'll go over that in just a minute in more detail. But she gave me like a list of ways to help with her treatment. And so, and I trusted her. You know, at the time, nothing about this made sense from what we were seeing, but there was still like, there was a trust there. And so for me, the hierarchy of trust was through from Dr. Fabian down to the family and then myself. So we worked very closely together. And then I went to the school administrators, our principal and our assistant principal, sat down with them and shared the knowledge that they needed to have about this so that they would be able to support the child, support what I was saying in the school. And so I received that from them, and then I talked to the teachers, the volleyball coach, and we came up with a plan of action for what the school day needed to look like. And so, and again, we'll go over that in just a second. And then the school nurse, I brought her in at the time. This went against every fiber of her being, of medical, of her medical knowledge. And so what I was saying to her, I remember the day when I said, look, this looks like a grand mal seizure, but it's not. And she was like, like, she really looked at me like I was speaking another language. And she was like, I cannot be a part of this. And I was like, that is fine. Like, you need to understand what we're doing. I brought her in. She was understanding, but she was like, in these episodes, like, this is very hard for me not to call 911, because our protocol is always call 911. And so the next slide, please. What we did is we created like the key players in the school. And you can notice on here, we didn't include the school nurse just for her own mental health. She had knowledge, she knew what was going on, she was involved, and she would follow up after. But during these episodes, this was something that it did not make sense. Now, again, we're talking, this was almost a decade ago. So since this time, you know, it has, I think, become more of knowledge to everyone. But at this particular time, this wasn't something we had ever seen in our community, and it was a very rural school. And just, it wasn't, even in the social media world, that it hasn't advanced at this time like it is now. So this was something that was not really ever heard of in our area. And so our key players that we were involved was, of course, the parents and guardians. They got a call every time when there was an episode. They were wonderful to work with. Dr. Fabian, she was the head of everything. Myself, the teachers that needed to be involved that she had in class that particular year, those were the only teachers that were brought in. Of course, our administrators, and then the coaches that were involved. So those were our key players that we worked together to formulate a plan to help this particular student be successful that year. Next slide, please. So what we did, and this was through Dr. Fabian's recommendations, is the first thing was we worked with the parents and, of course, Dr. Fabian, to just try to understand specific needs that she had in those moments, specific triggers, because she was able to identify within herself. She knew the onset of what her body felt like before there was an episode. And so we went ahead and prepared ahead of time a plan of action. So she had a safe space outside of the classroom. When she started feeling this way, she would go outside the classroom, and we had like places designed in the school close to every classroom to where it was like an area, like an office space or even a closet that wasn't utilized, that there was nothing in it. She would have that. If there was enough time, she could come to my room. There was a space in there for her. But we had different designated places throughout the school of where she would, that was safe for her. And then we always had a peer that was assigned to her, that was her best friend, closest friend, that knew exactly what was going on, that was brought in. And so she was like her person to always come and get me in the school so that I could be close by. I didn't give attention to it, but I would be outside the door where I could see, make sure she was safe, call the family. And so we had that plan of action, and it worked. We talked to the classroom, without breaching any confidentiality with her classmates. It was a very small school, so we were like a family, and so we relied on our class family to just have that understanding of empathy, of just, this is something that right now that your friend is going through, and we're going to help her through it. And so if you see that she starts having these symptoms, then I need, this is what we need from you as a class. And one thing was we didn't want to single her out. We didn't want to draw attention to her symptoms. And the teachers, I mean, they did a great job with making sure that happened. And her classmates did as well. Just staying calm. I'm gonna be honest, like a few times I was thinking, oh my goodness, like I had to like take deep breaths to self-regulate myself so that I could co-regulate with her so that she would, not sense that, because there were some scary moments that I saw. One time, actually, her body started drawing up like she was paralyzed, like, she was experiencing paralysis. And so just having that, that calmness at all times, having that person that was able to do that. And for the adults as well, keeping all the adults away so that there wasn't even more attention given in that moment. And then, of course, like Julie said, is just implementing that plan to protect her. For her, it was a 504 plan, just to make sure that there was never any problems with her making up work, leaving the room, just more protecting to make sure that she was getting what she needed, and the teachers needed that protection, so they knew like a plan, and that what they were doing was everybody signed off on that we were all in this journey together. Next slide, please. So we had everything put in place for the school. And we were doing very well with all the challenges that we had in that controlled environment. One thing I didn't prepare for is she was our school mascot. And so when you were on the field on a Friday night and something happens, then you can't control the stand of people that are the audience that's watching and all the medical personnel that's in the audience. And so she actually started having it looked like a complete grand mal seizure, the convulsions. And so I got the head off of her, and we were trying to, help her get through it, and trying to get her to a space where she was away from everybody, and everyone gathered around. There were nurses, there were doctors, there were medics. So everybody gathered around. Well, what that did was intensify the symptoms. Then she starts projectile vomiting, and they're like calling 911. And I'm trying to say, no, we don't call 911. No, let's don't do that. And which was very confusing to everyone. And of course, because of confidentiality, you're not going to share her story. That wasn't even my place, but trying to help the family get control of the situation where there was no control. I mean, they called Life Flight in to come in. And so they were disregarding anything that the family was saying, what I was trying to say, the administrator was trying to help support me. And so that we were not really prepared for that piece of it. And I remember calling Dr. Fabian that Monday. She ended up going to Children's, of course, was released and came home after she was pumped full of all the medications that her body did not need, which was, harmful, which is what we don't want. And I remember calling Dr. Fabian and, just saying, I need help. Like, how did this happen? And did I just completely like put her back in treatment? Like, is she going to regress? And Dr. Fabian was like, and what do we do? Do we take her out of the spotlight, remove her from this position? And I remember her saying, no, that's going to be more harmful. She needs to keep going. We need to plow through. And so as soon as if she has to be on the football, because she was in part of a routine, we had a dance routine and the mascot was part of it. She was like, if she needs to, then as soon as you come off the field, you go behind the bleachers. Like, you get her to a place. Like, don't ever like take her from what we have lined up for her, because we're making gains, there's success, like we've got to keep pushing through. And so, and I, and that was at the expense a lot of my credibility, which I did not care because it was to save a child. And so, because there was a lot of questions on, why would we allow her when we know that there's some medical stuff going on, but that worked itself out. And so she ended up continuing to be our mascot, and we had a plan. And after every time when she was on the field or anything, we got her. I even would get her to my office back in the school. I kept it unlocked, and me and her mom would get her there so that we could calm down, because after every big event like that, we knew that we were going to have some kind of version of that episode. So we were able to work through that and prepare better for those external challenges that we didn't think about going in. Next slide, please. So just to overcome the challenges is just really giving the educators power and understanding that they are instrumental in the success of that child, and that we, creating that trust and relationship with whoever the mental health provider is and the parents. Those are the key components. And then creating that supportive environment that enables the students to thrive academically and socially, because at the end of the day, we're not just educating, we're trying to produce really good humans that have all their needs met. It's not just reading and math. If they're not well, they're not going to learn. So we've got to make sure it always address the mental health part first, and then academically we can catch them up. But if they're not okay, then we're like hamsters on a wheel. We're not going to ever, be able to get them to meet their fullest potential unless we can keep them in a healthy mindset. So I think that's all. Let's see. Oh, last slide. This is the biggest. So my child, through the help of Dr. Fabian, I just cannot thank enough. She ended up that year as a junior. She, over a period of 8 months, her episodes decreased tremendously in frequency and duration. Her senior year, she had no episodes at school. And now she's 27 and she lives independently and has a full-time job. So it was a success story. So
the present time. So that's really exciting to hear.
yeah.
Thank you so much, Tanya. I mean, I'm sure many of the people on this call are partly thinking like, we wish we had somebody we could work with just like you in the school setting, because I think you're one of few and far between. I mean, I think we as providers need to do a better job of making sure we are directly communicating with people in the school setting, but it really matters who you're actually talking to there on the other end. So I know that the reason that this girl is doing so well is because she had you in her corner. So you're really, really wonderful. I do, again, want to thank Julie and Tanya for your time today. We have a few minutes left, and I did want to spend some time just since both of you probably have great insights. There were just a couple other questions that did come in, and then I wanted to leave it open to see if other people just wanted to come off mute and ask or type them in. That's fine. Couple of questions that were asked was, and feel free, Caitlin and Aaron, if you guys have thoughts about these two, please feel free to answer them as well. But what do you recommend regarding the use of equipment like or assistive devices? So wheelchairs, manual wheelchairs, AAC devices, things like that. Does anybody feel free? Anybody who wants to answer?
So a lot of times, because I come from a rehab setting, a lot of times we're trying to eliminate the use of any kind of adaptive equipment through the therapeutic rehab setting. So I always recommend to the school that we continue that process, have those things available if the student needs them, but not to offer them unless the student asks. I've had instances where students say, well, I was able to walk in the rehab setting, but now I have to walk really far to get to the gym or really far to get to another building. So can I just have a wheelchair as a backup? Oftentimes what happens is they have the wheelchair as the backup, but they never ask for it. I think it's just that sense of security that it's there. So really, again, it goes back to the education of the school, like really educating the school on when it's appropriate to use. Obviously, if somebody has episodes like Tanya described her student, it might be appropriate to use to get somebody for a long distance, but I just really rely on our therapy team to make those recommendations.
I agree with that too. I basically see as like, do I have to make a decision between them going to school or not? And so, I would prefer that they not use anything. But if they have to have it to be able to go to school, I would rather them go and keep their normal routine, and at the same time working to pull that away and making that really clear to the school too, of like, this is the accommodation now, and we're going to work to change that pretty quickly as much as we can.
Right. And the beauty of a 504 plan is if those accommodations are on the 504 plan, I often ask for a 30-day review and say, you know what, like on the day of the first 504 plan, let's review this in 30 days and see where we're at. And if they haven't used it in that 30 days, we pull that as an accommodation. And I think that's a fair way to do it. And it feels safer to the student, I think.
Lovely. I agree with that. All of that. This is a bit of a tricky one. How would you approach communication with school teams when there are medical providers that are in disagreement with the FND diagnosis?
Yep, that goes back to slide number one. Like the biggest challenge that I have are these conflicting recommendations from providers. So we might have psychologists who agree to one set of recommendations and medical providers who agree to a different set. And so a lot of times what we do is we go back to regardless of what the recommendations are, how does this diagnosis present during that 8 to 3 school day, right? How is the student presenting in that time, and what recommendations do we have for that student during that time? So if there is are you saying a medical provider who doesn't agree that it's FND, or is that what the question is?
It looks like, yeah, that there might be medical providers that may not agree with the diagnosis itself.
At the end of the day, it takes one provider's diagnosis to qualify for a 504. And so if there's a psychologist who has diagnosed a student with an FND diagnosis, then we would use that for the accommodations. I would rather err on the side of supporting the student rather than leaving somebody who may have a diagnosis out there that didn't get the accommodations that they needed.
Yeah. And
Tanya,
sorry. I was just going to say to your earlier point that I think as much as possible, we're trying to not have as many inconsistent recommendations coming from the medical team. So, whoever is asking this question, I think if there's ways to bring the medical providers together to try to kind of come to a consensus, if that's causing a lot of issues, I think that
if they're in communication, that could happen. Yeah.
Yeah. Sorry, Tanya, if you had other thoughts. Yeah. I think you answered this a little bit, but somebody asked, we have a plan in place for my kids with FND that outlines what FND is and what is recommended if they occur, but the schools tend to not follow the recommendations, which is signed by both myself and the neurologist, and they continue to call the ambulance every time. What's a good way to navigate this issue?
I personally, and Tanya, you might have input on this, but I would elevate that to the district level. So sometimes schools are making decisions at the school level, but they're doing it at the behest of the district. So they say, well, the policy in the district is to do X, Y, and Z, to call the ambulance. So then what I would do is call the district and say, who is making this policy and do they understand the diagnoses? So a lot of times it's really not at the school level that they're able to make those changes. And so I've had this happen all over the place. And so I call the district and try to get a hold of the head nursing folks and really get them to understand what this diagnosis is and why we don't want to call EMS.
I agree 100% with that. I think that a lot of times on the school level, it's out of fear. And so I think the awareness, the education on the school level, and then if that doesn't take care of it, then definitely the district needs to be involved with that.
I've never thought about suggesting going to the district level. That's a great idea.
I go there all the time.
In Alabama, we can tell them that we will call ADAP, the Alabama Advocacy Disabilities Program. And so it's basically like a nonprofit that really helps schools enforce, taking, the public schools anyway, following the ADA, recommendations that where recommendations are provided from providers. And so usually in Alabama that actually changes the behavior really fast. Doing telehealth in other states, I realize they don't have that resource in a lot of states, which is unfortunate. But sort of, and then even before I get there, really recommending or explaining what Tanya talked about of this really does, we understand it's scary, but keeping them here actually will change the kid's life. Like this actually in itself is treatment. And will keep you from having to deal with this all the time as well. The frequency decreases.
Yeah. I'm going to make time for one more. How do you approach it when you have a child who has significant functional symptoms but doesn't have an FND diagnosis? I know many of us are involved with other overlapping populations like dysautonomia or chronic pain patients, POTS patients. So I don't know if one thought I have is if they meet criteria for technically another medical diagnosis, that could be utilized, if not FND specifically. And they, I think the recommendations are quite similar across all of these overlapping diagnoses in terms of how to support them in school, but I don't know if other people have thoughts.
Yeah, and I would agree with that a chronic health impairment is a chronic health impairment, right? So if they have dysautonomia and they're presenting with certain symptoms in the school, those can be addressed. A lot of times the accommodations have to match the diagnosis, right? So if you have a diagnosis of POTS and then you're asking for recommendations that don't seem to make sense for POTS, then we might want to have that conversation with the family about, well, we're going to address the POTS symptoms in the school, but then let's talk to your provider about all of these other symptoms that don't quite line up with this POTS diagnosis so that we can help accommodate them in school. And so I think, again, that's that education piece, right? Like we want to help the families come to terms with the diagnosis. We also want to help the families make sure that they get the right providers around their child so that they are getting the correct diagnosis if they're having functional symptoms, but then also have all these other sort of cascading kinds of diagnoses. Which I don't think is uncommon for kids to get lots of different diagnoses before they hit that FND one.
Yeah, absolutely. Well, again, I know it's 1:31. Or Eastern. I want to be mindful of everyone's time. And again, just really want to thank all of you for making the time to attend today. If there were questions that you all had that didn't get answered, you can feel free to maybe send them to Caitlin and I. We're happy to pass them along to Julie or Tanya. I know one of the future webinars we're hoping to do is maybe talking a little bit more about overlapping diagnoses with FNSD. So POTS, chronic pain, amplified pain, all those types of things. So I know these conversations will be ongoing and also just how to support these kids in the school because that's such a crucial part of their treatment. But yeah, thank you everyone for joining. I hope everyone has a great rest of their day. And thanks again for you guys and your time.
Thank you, Risha and
And
Caitlin. Thank
also,
you.
if you're able to
Oh.
provide feedback, sorry, the link was restricted, but it should be working now. So we appreciate any feedback, including ideas for our future webinars. So thank you again, Tanya and Julie, as well as Richa and Aaron. We hope this was helpful and look forward to upcoming webinars.
Thanks, everyone.
Thank you.
Thanks,
Bye.
everyone.
Thank you, Julie and Tanya. It was great.
Bye. Thank you.
Thank you.